Oh, me again. Hope any
Dave, were we
everyone's
supposed to Dave, were we
sorry.
supposed to prep for the cervical spine like first one, or are we wrapping up lumbar spine with like those case reports?
We're going to do a little bit more on the lumbar spine, probably these next 2 weeks, just because we got a little late jump on the lumbar spine. And what I want to play with too, in the past, what we did is like we almost do a little wrap up and we immediately jump to the next topic. But I want to see we spend, I'm going to open up cervical spine, but I want to spend a little bit more time with us just going over the lumbar spine, just so it's not like, bam, we did all this work and then poof, it's gone and we're on to the next thing. So probably these next 2 weeks, I'm gonna go with Eric, and we may do just maybe a couple different cases with the lumbar spine just to try and really solidify it for everybody. And I'll put out a little bit of a schedule, probably coming up tomorrow or Saturday, on what the Zooms and what we'll do leading into the next sections will be like. So I'll open up the cervical spine then, put it out. Until then, I just figured everyone's usually burnt out a couple days. So I know you don't rush to get it up this week. Does that make sense, Lizzie?
Yeah, that's perfect. Thank you.
So yeah, no, I had no expectations of you to review anything this week. If that's your question. Other than I sent out some stuff yesterday. Just to there, because it's always been kind of the one thing is like, oh, the course was great, but boy, I wish there was more exercise. And as you can see, there's not really much extra time in the weekends that we spend to really kind of get into that with any real detail. So this is our stab at it, and we'll see how it goes. Now, I put together some things and I went with the flexion pattern because this is described reflection syndrome because it's described by several different authors. But you think about this one, it also ties very nicely into, what are we doing with most people with a lumbar back pain? It's can they maintain a neutral lumbar spine during flexion or loading based activities? So though we talk about like, okay, the syndrome or the flex segment, which we'll look at, the rehabilitation portion of it kind of goes, we can take this and apply it across different broader spectrums. But again, it's none of it's a one size fit all. For any patient you have, you're going to need a little bit more of this, a little bit less of that, depending on the individual. So this isn't by any means prescriptive. It's just to give everyone kind of a general kind of some range of thoughts, pull some things together. And Eric, I put most of it together, so by all means, go freewheeling on this one. Give your thoughts, kind of what you see, what you do. Just go see what we can do with this. And again, starting off here, we'll look at like, well, actually, first, any lingering questions about information from the course? I know it's kind of a hard thing to pop out there. If you do and don't want to do it here, by all means, use the discussion board or email Eric or I as they come up, and they will come up. And yeah,
Dave,
hopefully they're in.
this is more of a housekeeping question as far as just organizing the material in my brain and where we're supposed to be. Are we supposed to take the lumbar spine quiz and kind of finish all of that up by the end of this week?
Next 2 weeks is fine.
Okay.
Okay. It's not going to close.
Okay.
So if you need a little decompression time, gotta get settled back in with the family, just can't bring yourself to do it on a Saturday afternoon. Understood. Okay. Okay. Flexion patterns and syndromes. A few people describe this, but again, as we talk about this, in the back of your mind, think about potentially your disc patient, your other back pain patient who may not fall cleanly into a subcategory, but we're going to control these forces just the same, even if it's your CrossFitter or your Olympic lifter. Biomechanical features, excessive lumbar flexion is kind of predominant where, dominance for lumbar flexion in the task where hip and thoracic movement should predominate, or in many ways, I think be better balanced. Like this movement should flow through the system and not be isolated to one particular area. You know, in many cases, you know, flexion is in either these segments are already flexed before they start to move, or they initiate the motion with a lumbar flexion early. As we talked about, you have joints that are very small, size of a nail, versus something a little bit smaller than my fist. You know, with this, many times you can have the lumbar even flexing beyond its normal functional range of movement with these positions, whether it's prolonged sitting, whether it's forward bending. And this is going to place increased stresses on intervertebral discs, posterior spinal structures, as these take more of the load with that increased flexion. We talked about somebody who may have a flat back posture. As they go into full flexion and they get full flexion, that you're starting from 0 degrees like lordosis, and you're going to 56 degrees of flexion, which is considered the normal range. It's a big difference if you're starting with a 14 or 15 degrees of lordosis and then going 56 degrees, because then you're only in 30 some degrees of flexion. So the starting position and how much they flex will matter. Any loss of neutral spine position or failure to maintain the lordosis, these structures during motion will do it. Again, poor load sharing can also occur in between lumbar segments, driving more through the lower lumbar segments than the upper lumbar segments. We talked about associated weakness, underutilization of key stabilizing muscles. You know, key stabilizers in this case could be multifidus, transverse abdominis. You know, gluteals could be underactive. You know, you can also make an argument that in some cases the gluteal muscles may be overactive, as we talked about in butt gripping. So now I can't release the pelvis, so the motion happens more quickly through the lumbar spine. So as we look at things, it's always good to know that here's the general common things we see. And when I see an outlier, don't get too perturbed by it. Just trying to interpret what you're finding. Again, over time, you're going to get potential loss of passive stability structures, facet joints, neutral zones, ligament, late tension relationships, posterior disc, those structures get impaired and you get expanded neutral zones. And again, you know, structural considerations, you know, lack of hip mobility, you know, shortened posterior chain musculature, you know, poor thoracic spine, you know, extension. These all contribute to excessive lumbar motion. You know, pain mechanisms that we have, peripheral nociception. You know, repeated strain on these structures can create peripheral nociceptive pain, which again is different than the other pain qualities we have. Central sensitization is going to be more related to central nervous system sensitivity from the repeated nociceptive input. So we get a facilitated pathway, the spinal cord, midbrain, or higher cortical centers. Referred pain, again, would be radiating to surrounding tissues, often referred into the hips, SI joint, you know, other regions locally. Again, note the difference between, again, what we have referred pain as peripheral nociception pain and radicular symptoms. Now, if we're getting neural irritation with this, then we know that, you know, we have neural compression or irritation, either from posterior lateral disc and compression, inflammation around the nerve.
Dave, can I make a clarification of some of that stuff?
Sure.
So I always want to make sure that people understand the difference between referred pain and radiating pain. Radiating pain from a technical perspective is going to be more your lancinating neurological type pain. Okay, this is stuff that's caused by neurological tissue damage, compression, inflammation, all these, you know, chemical irritation from inflammation, all these different things. These things will be more consistent with disc injuries, that sort of stuff. Referred pain is more somatic pain. Okay, and I'm talking from a technical sense as far as definitions go. These things often take repetitive stresses in order to start to produce a reference into a different body region. So either some sort of sustained position or repetitive movement, something like even something like walking can cause posterior leg pain, but it's more this dull, achy, you know, maybe burning type of pain, but it's not this lightning bolt sort of thing that's shooting down your leg. So I always want to make sure that, because I will specifically reference these things with those sort of terms. So I want to make sure everybody has that kind of in their head, that there's kind of two different terminologies there. Referred being more of a somatic pain from a somatic structure, like, you know, irritation of a facet joint, versus radiating pain being more consistent with neurological involvement.
Oh, okay, okay.
In terms of referred pain, is there like a consistent pattern of different areas that we would see for referred pain? You know, like I just remember from PT school, they would talk about different organ systems refer to the left shoulder versus the right shoulder. In the lumbar spine, is there a pattern that we can anticipate if we're getting, you know, secondary pain in this area where we can differentiate that, yes, that's in fact referred, or is it kind of more generalized?
It can be different depending on what structure it is, right? So if we're dealing with something at L3, it's going to be different than L5, something along those lines, versus you know, the SI joint. You'll start to notice there are relatively, I should say, consistent patterns with each different area. You'll tend to see referenced pain kind of similar to, you know, like where the dermatomes are. So for L5, you might see more lateral hip, you might see posterior leg, but it's not necessarily going to get down below the knee in most cases. You can have some issues with it from time to time, but I tend to notice more of these references staying above the knee. Lancinating pain is going to go down the whole thing. It's going to shoot down from the lower back most of the time, all the way into the foot and leg. And it's going to be a very distinct type of pain. Okay, so it will depend on what structure it is and what level that the reference is coming from. So, for instance, the case that was sent out on the message board over this week, looking at, you know, groin pain, looking at, you know, testicular pain, things like that. The T12 segment is actually embryologically where the testes originate from during development. So it's really pretty common. I saw a lot of posts about upper lumbar spine dysfunction and things of that sort of nature, which is pretty close. But it's usually TL junction problems that will reference pain into that region for men specifically. So it's different than, obviously, where that refers to is different than it would be if it's L5, right? So we do have to be kind of conscientious of the segmental level that's available with that. In most cases, if you're developing referenced pain, like again, like I was saying, this will have to be some sort of repetitive or sustained irritation of these tissues that's going to be able to create this somatic referred pain. In most of these cases, you're also going to have facilitatory effects that are going to be associated with it. So the pattern of reference, pattern of pain reference that you're looking at doesn't necessarily have to be diagnostic because it's not an objective thing that we can test for, right? But looking for facilitated velocity-dependent weakness is. Right. Same thing with looking for loss of muscle tone around the multifidi at a specific segment, the scratch test, all these sort of things. They're more consistent, objectifiable tests that we can do. So I wouldn't get too hung up on, oh, somebody comes in and they're pointing to these different regions on their you know, lower extremity, and kind of being able to diagnose where it's coming from based off of that reference. It's more of, okay, this is kind of a typical area where it might be this portion of the lumbar spine. I need to make sure that I have objectifiable tests to look at here to determine if that's really the case and what level would be involved with that. Does that make sense?
Yeah, thank you.
A little long-winded, but hopefully it helps.
It's good because, as Eric alluded to, if you look at what we're doing here and you're thinking about the case that was posted, it's similar to the process you're going to use for the other lumbar cases. Well, what do I have? Do I have, you know, referred pain? Do I have radicular pain? You know, is it lancinating pain going into there? Helps kind of further delineate what kind of problem we're going to have. That's kind of where I see that case. That's the first thing I would think of is I need to sort out what exactly do I have coming into that segment, into the testing, what's describing that. And where's that being referred from? And then the rest of your exam that we look at, we can rule out other things. We can look at the hip and rule out and screen out the hip. Look at other things, you know, the other things can be tested out. So this kind of thing, you know, psychosocial fear avoidance behaviors, you know, maladaptive beliefs in back pain, you know, those things are certainly things we're going to deal with. We don't spend a ton of our time and effort on teaching these areas. It's not really our focus, but we're always reading the patient and kind of seeing what's going on and what are their beliefs. I will, like within our conversation, we address this. They act like this is all new, and it's really not. Like we have a patient who's concerned about what's going on. I know one of the number one things I do for people is when I can give them hope, realistic hope, and I put them at ease. If I can do that in eval, that's a successful eval. To have them understand their problem, not feel overwhelmed by it, and understand their trajectory. And doing that is a lot of their treating their psychosocial factors without me going into, oh, I'm going to treat you psychosocially. It's in my speech cadence, it's in my word choice, it's in that part of my personality I feel like I need to bring out for them as we do that. And we're constantly addressing those things, but we're always reading those contexts. What is the thing that they're afraid of? And can I put them at ease for that? Movement dysfunctions, we want to observe the dynamic tasks, slouch, sitting, bending, in the spine rather than hips, lifting poor. And again, the patient's meaningful task. What is the thing that they do that reproduces their pain? What is that thing that's important to them that they've lost? And that's also kind of one of the best places to treat. If I can, I try and do something with that in the eval so that they see that, hey, I'm only already addressing their problem. I can positively, hopefully, impact their problem within the first session if all goes well. Okay. Underlining mechanisms of the pain pattern that we're going to see. Repetitive lumbar flexion increases stress on a lot of different structures. So we can kind of go things, anything that's going to restrain posterior, the posterior elements are going to be the common ones. We talk about altered neuromuscular patterns will be it too. So, I have full range of motion in my hips and thoracic spine, but I've been wired not to use it. My pattern generator is giving me a maladapted pattern where I'm driving these forces in excess through a range through the lumbar segments. So, and in there too, commonly what we see with these pain patterns, we're going to see over recruitment of some of the muscles. In these patterns, they talk about, okay, some of the flexor, the rectus abdominis, sometimes superficial rector spinae, under recruitment of, local stabilizers, multifidi, TA. And it could be under recruitment or delayed timing. Could be two things we're going to see. And many different schools on shortened muscle balances. They'll talk about psoas if it's a flexion pattern limiting mobility, force and compensatory flexion. I think if I see that, we talked about in the course, and Eric, again, your opinion on this too, is that if I see facilitation of that muscle, I'm generally going to treat the spinal segments first and then see what that muscle length does and can I get it to inhibit. Is that muscle facilitated because it's splinting or shunting versus is it actually shortened? Your
Yeah,
thoughts?
I would totally agree with that. I would say I very rarely see a legitimately shortened contractile
Mhm.
unit, where the structure of it has shortened. And again, most of the times you're going to see something like that is after some sort of long-term immobilization problem. More often than not, it is going to be these tone issues where we just have something that doesn't want to elongate the way that it's supposed to. And that's going to affect the ability of the joint to perform the way it's supposed to. It's going to affect its neutral zone. It's going to affect the axis of movement. It's going to affect the, co-contractions for stabilization, all these sort of things. So it definitely throws things into a fit when we're looking at how those sort of problems come out of the spine. Now, the spine is a unique thing because of it's more stable in flexion in general, right? And this is probably part of the reason we see some of these patterns is because of all the posterior elements, the posterior longitudinal ligaments and ligamentum flavum and the interspinous ligaments, plus the long paraspinal musculature. All of these things tighten up when the spine is in a lumbar in a flexed position, right? And so this tends to make the spine more stable. So people tend to try and find that stability in that position. That's why we see people, walking around with these kind of random, flexion positions of some of the lower lumbar segments. In most cases, the lower lumbar segments shouldn't really flex much at all, even with a forward bending moment. If you see somebody bend forward, we typically still see this kind of flattened portion, basically from 4-5 down to S1, where it doesn't really create much of a kyphosis there. So there's reasons for that as far as how the spine is meant to stabilize. Um, we can talk more about it as we go on here and kind of there's this osteoligamentous tube that's basically surrounded by the thoracolumbar fascia and then the posterior elements of the bony articulations themselves. And then the filler for that is typically the multifidi muscles. So as the multifidi contract, what it does is it compresses the facet joints together, and that makes that portion of the spine very rigid. So when we see somebody bend forward, we shouldn't see this real curvature through the entire lumbar spine, because as soon as we do that, we're going to tension the thoracolumbar fascia, which actually is very thick with type 3 mechanoreceptors, which are inhibitory receptors for muscle recruitment. And so when that sort of stuff happens, it tends to start to turn off some of these muscle tissues, and we don't get that adequate stabilization. So I can talk more about that as we go along, but it's a pretty unique process to help stabilize the spine for activities like bending forward and lifting, which in general are two very functional movements. And from an evolutionary perspective, we don't really realize that we can take out a dolly and carry and roll things down, with wheels and whatnot. We still think we need to be able to lift and carry things. So at least the body does. So a lot of good adaptations, but it does help understanding these processes so that when you go to rehab somebody that's having these movement dysfunctions, you can use these things to your benefit, because the body's natural innate processes for stability should be the methods that we're trying to facilitate, that we're trying to propagate for them. Because at that point, we're getting the central nervous system to work for us rather than trying to fight against us, if that makes sense. Again, more on that to come as we go along.
I pulled from a couple different texts, like the pattern of what they talk about. I guess the first image, on the image on the right here, they're talking about there is what you'll see is a flattening or even a flexion. Oh, probably what they're looking at, probably L4, L5 at this segment. And what you end up with there is hypertonic and stiff, erector spinae above it. So on the left-hand side, as this person flexes forward, you don't see much flexion coming from the upper thoracic spine, but that segment down in the lower lumbar spine on the right is already flexed. So you're going to get excessive stress and motion at that lumbar segment that's flexing. And this being a rigid lever here in that muscle tone there, not only is going to put extra stress into the lumbar spine, if you think about the spine being long there, in some ways it's short, it lengthens the lever on the lower back. By being able to flex the thoracic spine, the lever actually decreases and shortens versus it being longer. So that's another thing they'll look at as vector as far as lifting. If you're lifting and that back is straight and elongated, it's a longer lever arm into the lumbar spine, creating torque. So this image here is kind of giving you that sense of that what this patient may look like. And there's different variations of this and different strategies you will see. So this is just one of them. Here is somebody with, excessive, segmental flexion. And what's happened is she's going forward here, she's folding at the lumbar spine and her pelvis has not moved, sufficiently into that position. So her pelvis almost looks from that line on her pants still erect. And that flexion that she's achieved has been through the L5S1 segment and those lower lumbar segments. And again, they're talking here about that flexion moment happening basically from here, from L5 up to T6, where she's rounding through her back with the pelvis not flexing forward. So she's getting most of her forward flexion motion in from her back, lumbar spine. And her complaint, as they talked about, was pain with sitting, because she's probably in that rounded, elongated position.
And things like this are really difficult, because when we look at somebody that doesn't move well through the pelvis like this, there's I don't know if Dave showed it to you guys this weekend with SI joint screening and whatnot, but there's a kinetic test. It's called the forward bending test that has multiple stages to it. And basically there should be a kind of a tilt of the sacrum that's created by a co-contraction of the pelvic floor, the pubococcygeus, and the transverse abdominis. So if you're not able to achieve that sort of position, like this woman definitely isn't, you're going to have very poor recruitment of the transverse abdominis in this sort of position.
Yeah, we'll talk on, like, I put a whole section on cueing in here, more cueing than you'll ever need. And we're going to talk about like that exact mechanism, and we're looking at how the different authors cue that specifically. This one here, they're talking about almost like a posteriorly translated segment, which you'll see where this segment bumps out the back a bit, and you may see a bit of a hinge. Now, again, the translation, you can't think, well, what are the facet joints? The facet joints aren't separating like this. It's really kind of a kyphotic kind of moment where that superior vertebrae can kind of glide anterior. For that to happen, the facet joints generally need to be in a slightly flexed position, unless they're in a more sagittally oriented plane. But there's a flex segment. I think you'll see this. I see this like I know older people, the segment gets degenerative and it's kyphotic, and it'll appear this way. younger people in their 30s with an acute disc. It's a common segment I'll see in the acute disc. Eric, how about you? Bumping into this segment?
Yeah, I'll see that same sort of pattern with the ones you're just talking about. I'll also see it in patients that have had this is a little off topic, but with rotational issues, where there's a segment that'll start to break down with rotational problems, and what we'll get is we'll start seeing one of the spinous processes look more posterior, because technically it is more posterior, because the axis of movement is no longer in that posterior third of the disc with rotational things. It's kind of shifted off to one of the lateral components, either one of the facets or something of that nature. And so we start seeing these little translational things that'll occur. So it's another, I mean, it's kind of similar situation that what Dave was talking about. It just happens to be created by a different problem, more of a rotational issue.
Let's see here. And this was one from Peter Sullivan's articles on segmental instability. And there again, you can see like different examples on the right, just in that lower furry area. It's a little bit more flexed here. And then as he bends, you can see how it's kind of prominent, how he gets that prominent flexion there, probably L4, L5, or maybe even slightly above, but it's probably maybe 4, 5. And again, this position they're looking at here is in was it 4-point kneeling? So that one on the left, you got kneeling, and that's sitting. So it's one of the ways to kind of look at it, that you get that position there in the lumbar spine, which doesn't create increased stress. They don't have them forward flexing through there. But you can imagine this becomes the path of least resistance for this individual, or that their pattern movement. So they tend to drive through this. And again, he was even commenting here, as he said, it's a common with a flexion rotation injury. So just to give you some visualizations of, these are people with pure kind of flexion anomalies that are there. You see here, it's kind of in pattern. He's there at rest. This young lady may be moving through that, and she's probably flexed in standing. But we can see these patterns predominate. And again, also think about, as we get into the rehab portion of it, there's a lot of overlap in different areas in tweaking. That patient we have who's maybe recovering from the acute disc and they're in a middle phase may look very similar in the rehab program that we use for somebody who can't control this lumbar flexion, because they have pain, they have inhibition of multifidi, their systems are set off. There'll be a lot of overlap once we get to the later phases of movement, because the later phases of movement are, can I do functional activities and stabilize my spine? Can I build endurance in my spine for loading activity? Can I return to sport or return to activity? Those activities will start to blend and look a little bit more similar, but may diverge. Like, the guy who's just playing golf on the weekends, with his friends is one thing. The person playing, high school lacrosse is another. They need to be trained differently, and we don't need to overtrain those who are less active. Done a lot of the assessment. What we'll see static posture here is anterior, and even sometimes posteriorly pelvic, tilted pelvis. You can see the spine, the lumbar spine can respond to either one. What we can see. We can see a hyperlordosis or a flattening of the lumbar spine, which is probably accompanying the anterior and posterior pelvic tilt. Alignment of the thoracolumbar region in hips can dictate a flexion posture. So depending on where my hips or the curve in my thoracolumbar region, all these things can contribute. So you can kind of look at your individual and say, hey, I have a flex segment here. What's the lay of the land of the pelvis? What's the lay of the land of the thoracic spine? With forward bending, we expect to see lumbar flexion is excessive. It's either fast or the timing of it's off. Like somebody can reach down and touch the ground and end up in a normal range, and two people can get to the same end point. But if that one person did it with a predominantly lumbar flexion, with the other motions coming in late, the timing sequence is off. And so the load distribution to the lumbar spine is off. So even though my endpoint might be the same and these look similar, how they got there will matter. So I want to look at how they got there in those mechanics. Lumbar spine should be flexed to more of a neutral position in most people, with very little flexion in the lumbar segments. You're usually flexing to neutral in this position. You're going from a lordotic position. They usually end up in full flexion in a more of a neutral position versus the lumbar segments being flexed. So if you see flexion and rounding in the lumbar segments, that's your first clue. Again, to talk about gait analysis, they'll talk about over reliance on lumbar motions. The person, you may see excessive lumbar motion versus hip extension or pelvic rotation. And again, what we want to do is observe the daily activities. We expect to see this happening in sitting. We expect to see this happen in forward bending. What other activities are they having trouble with? Is it sitting at work? So what are those activities that are their primary complaints? That's always a great place to at least stress one of those in the eval. You want to try and take away one painful pattern. That way you get a success in the first session that costs you very little. Again, your scanning exam is going to be your range of motion, your active passive resistive testing, manual muscle testing, neurological testing, and your screening. Again, may not be the absolute first thing you do, but you're going to have it in there somewhere with these individuals. These patients may not be they're not having if they don't have radicular or lancinating pain, then my neurological testing isn't probably the first thing I'm thinking of. I'm going to look at some of these other things, but my neurological testing will be part of my bias correction and search for etiologies. Palpation, we're going to look at muscle tone, spinal stiffness, tenderness. What is the lay of the land? Looking for hypertonic muscles. Muscles that are often described in these patterns are going to be anterior muscles. They talk about okay, are they more rectus abdominis and like a chest gripper, or they have back gripper, which would be the erector spinae. Hamstrings, generally I'm going to think facilitated if I'm seeing that. Why are my hamstrings hypertonic? Why are they restricting the pelvis? Is this a habitual pattern? Is this a stabilizing strategy? And again, you can see glutes if they're hypertonic, and that would be your butt gripper pattern. And again, your gluteus maximus and medius and multifidi in your inhibition pattern. But again, this can really vary from individual to individual in their facilitation inhibition pattern, but we can assume that this is kind of a general starting point. Pivums and pavums, want to know, do I have a hypermobility? Is there a subluxation within here driving this? Again, the patient narrative, as we talked about, understanding beliefs, fears, and their habits. What's contributing to this thing? Get to understand the lay of the land. What are they afraid of? What small things are they doing on a daily basis to chew this up? I included in here more as a reference point some of the authors who published on these different topics. And it's nice to have these external cues. I probably have like 20 of them in here, which is way too many. We're going to go over the general concepts, because what you're going to want to do is go in here and pull out the ones that work for you. And if you have ones that work for you that kind of match this, then use the one that's working for you. But it is also, each one is kind of biased by that author's kind of background. Like, Peter O'Sullivan is more about, reducing predictive bracing, trying to desensitize the movement, fear avoidance and pain beliefs. That's why it's that cognitive functional therapy model that he's kind of developed into. So his terms of like letting go of the belly, to move more naturally, to decrease the flexion pattern, relax your back, it's strong and your back is safe to move, getting that person to kind of know that it is okay to move and to relax those longer vectors to allow the upper spine to flex. You'll see commonly in there, do I need somebody who needs breathing and relaxation? Not only to encourage diaphragmatic breathing, but proper disassociation of, breathing and stabilization. Because you have those individuals where these become very coupled and very splinted. So for some of your patients, you're going to focus on breathing exercises to uncouple these mechanics. Somebody who may be a butt gripper, as we talked about, you identify that as, how do I teach them to release the gluteal muscles? To kind of get them to feel, where there's palpation, can I turn these muscles off? How do I desensitize these?
I always chuckle at that one. Unclench. It sounds like something you'd say to your wife.
Uh-huh. Yeah. Right before you have a quiet evening.
Right before you sleep on the couch, right?
Yeah. So I'm now only allowed to think it. Got it. Hey, Shirley Sauerman, movement system impairments, very muscular driven system. We hear her, everything is a you're gonna think very muscular pattern in her approaches. So in her cues, you're gonna kind of get a very muscular postural, approach. Moving with your hips and not your back. That's the hinging through. How do I cue that person to hinge their hips? feeling your sit bone instead of your tailbone. Am I sitting with a slight lordosis is what that cue gives me. Can I create that lordotic curve to take the flexion stress out of my back? Keep your back quiet and let your hips do the work. That's going to be for that lumbar gripping pattern in that person who may be, overtoning. Maintaining that small curve in your back. Again, that lordotic posture, that neutral posture is very efficient. We're not overusing, external, basically erector spinae. We're not hypertonic in our abdominal muscles. So you'll see each one of these approaches, and I could read through all this, but that would be a pretty boring hour. What you want to go through here and see the main things. Like Diane Lee is going to talk a little bit more about the thorax and stacking the thorax. Breathing in there as well. Tucking the pelvis when you squat, which is a common theme. Of letting your pelvis tuck under you when you squat. And again, that idea that we talked about, I mentioned in class, of aligning your pubic bone and your sternum when in standing. Am I stacked or am I unstacked, requiring additional either facet joint or ligamentous load or muscular activation? Stuart McGill is one of the little divergent, especially when you compare him to the one beneath with Paul Hodges. Stuart McGill he's looking at the system as bracing. He is not in the motor control camp. His approach is more that, hey, this system acts more like plywood, and that when you glue wood together in different layers, you create stability. And he looks at the system as giving more general cueing and grooving postures more than deep system activation being his approach. Again, it can be confusing because you have conflicting opinions in here, but I think it's also important to understand so you can talk to other professionals to understand where they may be coming from. So that person's been, hey, there's a Stuart McGill guy because I just read his book. This is going to be his mindset. And the therapist around you or professional or trainer. Okay, if they're a Paul Hodges and motor control person, they're going to drop down in here and there. And in the pelvic floor camp, you're going to be much more Paul Hodges, Carolyn Richardson driven in your approach than Stuart McGill. As we talked about in class, is that you want to be able to do is to be a little bit more Paul Hodges when you need to be, and you can be a little bit more Stuart McGill in other cases. Or do I need to be a little bit more Paul Hodges in phase one? And okay, once I'm in phase two, now we're looking more like a Stuart McGill approach. So not everyone needs motor control exercises, but those who do need it. They do need the timing and those coordination things set. So I will move between them depending on where I feel like this patient needs to be. And that's kind of our role in this, to decide when to do it. If you're not sure, early on, what you're going to do is you're going to hedge your bet. What does it cost me to do 7 or 8 minutes of motor control exercises before I go on and now I'm going to teach them to brace and squat and do my higher level activities? So my risk reward is there. So I don't have any qualms of, hey, we're going to spend a few minutes, connect to the deep system, and then we'll go on to our bigger stuff. And you'll see here is that, again, Paul Hodges will be, all your cues here will be your breathing, your drawing in, and your cueing of your deep muscles. I'm sure the pelvic health therapists have some rather colorful ones and some other interesting ones that are good to use. Again, this is not all encompassing, but I want you to go in here and think about, hey, what are the ones that may work for me? Can I play with some of these cues? How do I cue my patient to work on these subsystems? So I thought this was good to have because I'm going to give you a bunch of exercises after this, and that list is by no means exhaustive. But phase one should be cueing in this activation of what I need to do. So find what works for you. If you have other ones that work for you, please don't abandon them. Okay. This is not prescriptive. I picked a 5-stage program, and I realize it's kind of a bit of a random. It's like when you look at a lot of Stuart McGill's and some other programs, 5 stages is kind of what they use. So I figured, okay, I'll just use that as a framework for this. And the challenge with this is that you have multiple systems which overlap and in some ways compete with each other. But I wanted to see, could I blend them all together a bit to give you an understanding of what is out there in research, what do you see, why are you seeing it? And again, may diverge from this because you have a different exercise or one that works for that individual, completely fine. Okay. This is not the Bible. So let's think about this. Courtney, phase one here, postural correction and awareness, somebody with a flexion pattern. Let's look at these first 2 or 3 exercises. What do you think of the sit in the lumbar support using the roll? What do those exercises kind of give us, or what do those corrections do? Yes, this is the portion where I start calling on everybody.
The postural correction,
Yeah.
sitting with a lumbar support, what does it do?
Yeah, for this individual.
It just gives them like external cueing and awareness to their, I think I like to do that sometimes just to make them aware that they're in a posture that may be contributing to their symptoms.
Yeah.
Is that what
You
you're
use it for,
wondering? Like,
yeah. Like we're looking for, I use it as a position of ease. Does this put this person in a
yeah,
position of ease? Set joints are in a neutral zone. I've decreased muscle activation. Pain goes down. I probably use the lumbar support almost more for cervical patients sometimes than I actually do lumbar patients to a degree, just because I want the spine centered and the head centered. Standing posture, weight shifting forward on the balls of your feet, without overarching your back. How about that one? What does that one do for us? All right, this is your last one, Courtney, then I'll move on to Lauren.
it just puts it just unloads that spine. Does that make sense? I don't know. I hardly ever do that.
And somebody with a low flat back is we have somebody where we want to get the back out of a flex position or forward flexed into a neutral
Yeah.
position. So, by shifting weight forward, it's almost as if that's one way to cue. If I wanted to almost like anteriorly tilt the pelvis, do I play with the anterior posterior tilt of the pelvis to induce more of a natural lordosis in somebody who may have a flatter back? So I don't need to use this on everybody, but say this individual who is somewhat flexed or flat back position. Again, one of the goals of these movement patterns, these corrections, is can I get the spine back to a more of a neutral alignment to better share and distribute forces? And that's what these first cues are really all about, from supine neutral, spine awareness. Can they get their spine into a neutral position? Can they get it to a comfortable position where it's supported but not flattened? Most people have a little bit of a lordosis in that position. The spine generally is not going to be resting flat on the bed. And then, incorporating breathing techniques as well, just to kind of create some relaxation if they're hypertonic. And again, back in here we have transverse abdominis activation in phase one. Ergonomic correction and sitting in the chair is going to be important in most individuals we see. Here we're going to introduce pain-free hip hinging and awareness to maintain a neutral spine. That's the idea of bending from the hips and not the back. Once they learn to activate the deep system, can they now take that into their movement pattern, where they can keep as Stuart McGill called grooving a neutral spine is the term I like. Can I maintain a neutral lumbar spine as I go to hinge in the timing mechanism? Again, Stuart McGill in there is more of a general approach, different than the motor control, is that bracing, as if you're expecting a punch. And that's that global system, where the other ones are going to cue, okay, I want to feel deep system without internal, external oblique system firing. Stuart McGill is more the model of this is plywood. So his cueing in a phase one is going to be slightly different. So again, what you want to do is if these are pelvic floor patients, especially, I think you're going to see a lot of pelvic floor TA firing problems. So you're going to want that motor control patterning at first. Somebody who's coming in with a movement pattern impairment may not require as much deep system training, and they may do better as they move on into a more of a global bracing. Eric, your thoughts? Do you move between systems?
Yeah, I would say I have to. I feel like I have kind of used my own sort of thought processes on a lot of this stuff, but the general purpose, the way that I look at this sort of phase, like I use a 3-phase version of this sort of thing,
Mm.
but I'm looking at this as a recruitment phase. I just need these muscles to be turning on at appropriate times, right? So the timing, the cueing, all that sort of stuff has to be appropriate. But my biggest overarching thought that I have when I look through these sort of things, especially Shirley Sarmons and um,
Mm.
and Stewards, these sort of things where they're like, they're talking about voluntarily cueing what muscles that should be basically
Yeah.
automatically turning on, right? They should be reflexively turning on for us. So when I see that sort of thing, and we spend, and like I said, I just don't spend a ton of time doing the, lay on your back and hollow out the abdominals, and feel your
Mhm.
multifidi swell into your finger and those sort of things, because these are things that should be, like I said, reflexive. They should be automatic. So I try and cue certain movement patterns that will reflexively recruit these muscles and get them to turn on in low load, low impact situations. So I guess you would kind of say that I'm kind of using multiple versions of this. I think I kind of
Yeah.
more toward Diane Lee with trying to
Mhm.
stack things and get things to turn on the way that they're supposed to. But I try and avoid the voluntary components of it, just because when I think about it, if I'm going from laying down to sitting up, the first thing that runs through my mind is not, okay, I have to cue my transverse abdominis and my multifidi so that I can maintain a neutral posture. Nobody's doing that, right? Most people, when
Mhm.
they're going from laying down to sitting up, is, I hope I don't step on a Lego that my kid left on the floor next to the couch, right? So
Mhm.
I'd rather it be a reflexive component. But it's not that it doesn't work. It's just a matter of kind of where your headspace is at. Is this not turning on because of a muscle weakness or because of some sort of inhibition? If it's an inhibition, there's a reason for the inhibition, right? And I feel like a lot of times, if we can remove the causes for the inhibition, the reflexive recruitment will start to return pretty quickly. And so that to me is the way that I've kind of modeled my practice out, and certainly my rehab components out of it. I think we do a lot of the same things here, Dave. You just have split it
Yeah.
up 5 versus the 3 that I use. So
Yeah, and that's what you see is like I do use some of the TA motor control training. I look at it. I don't linger on it very long. Once if I find they're going to force closure issue somewhere, once I can get them to connect that you have less pain when you do this, then that's my retraining with them. It's like, can they control their pain? And once they realize, oh, I can, test, retest it, that's what I'm looking for when I'm looking at retraining. To retrain it in the absence of that, I think it's much harder to do.
yeah,
And that's kind of what we did in the class, where they were looking at the active straight leg raise, form closure of the pelvis, is looking at, okay, can I retest it and get it to go? Much like with the single leg balance with TA activation, a single leg, they have this in here phase 1. This could easily be in a phase 2 of, motor reeducation, core activation, to say, okay, can I stabilize everything when I go to load my leg?
yeah.
So,
But these are dynamic movements that we're talking about, right? We're not just laying flat on a table telling them to hollow out their abdomen, right?
yeah.
At least in most cases, right? There's some people that need it to get out of a pain state, right? Most of the stuff that I do in my initial recruitment phase is, this person comes in and they're hurting, and they need these things in order to help get them out of that pain state, so that I can progress to more dynamic movements, more loaded movements, these sort of things that they need to be able to accomplish to achieve that meaningful task that we keep talking about. But yeah, I mean, again, it's just it's a preference, basically based on what you've seen and what has been effective for everybody, right? So there's no reason not to try all of these different things, or different cues, or different exercises, because they all can be very useful at times.
Yeah, it's just matching up where your flow is with that individual.
Yeah, correct.
you know, Postural correction here in this quadruped rock back. I think of this as a neutral spine. You're really looking at hip mobility. So if somebody has a hip restriction and it'll also posterior glide, you'll certainly see, as we talked about, the pelvis rotating rock around it. But with the quadruped rock back, this is really that early phase of, can I stabilize my spine, rock back, and maintain a neutral spine? How quickly does my lower back flex? And if I use this, I'm using them to train forward flexion with a neutral spine. So quadruped rock back with weight support on the hands is an easier version of it. My progression sometimes is, I will do it kneeling. And can they do a sit back from a high kneeling to sit back onto their heels, maintaining the neutral spine? So my progression on that would be that. And that comes from Stuart McGill. I'll do that with a weighted bar, and I'll do that with a cable pull down as one of my early training exercises for the lumbar spine as I get in there. So I'll go from quadruped rock back, they can maintain neutral spine, tall kneeling, rock back, neutral spine, do it with load, do it with another force, and then kind of go from there. Yeah, I'll mix that in with probably, you'll see later on here, probably, give double leg hip hinging, and then we'll get into single leg hip hinging. Kind of from Shirley Sauerman here, we have seated lumbar activation with hip flexion. Can they sit and raise their leg up, without there being an alteration or any shifting? And we looked at that of hip centration. Can they stabilize the deep system, and keep everything coordinated without compensatory lumbar flexion? So if they lift their leg up and seated and the lumbar spine flexes, they can't control their lower back. So this is one where, yeah, here in number 2, could it easily be in number 1? Yeah. Side plank on knees with lumbar neutral, your classic kind of part of now getting into a modified version of your McGill Big Three, which are your Big Three stabilization exercises. And how long do you like your side planks or your planks for, Eric?
I'm looking at minimum of a minute.
Okay.
The way that I do it, I use planks as like a carryover type of exercise. When people get through the routine that I usually put them through, and they say, "What should I do now?" It's like, well, you can keep going through this because you can continue to get stronger. You just, keep cycling through these last 2 phases. Or if you want more of a maintenance thing, planks are where I go. And I usually ask people to accumulate a full 5 minutes. So it doesn't have to be 5 minutes straight. That's very difficult to do. Even people that aren't having pain and are in very good shape can't do that. But you say, okay, get yourself into a plank position and go for as long as you can. You take a break, you hit the pause button on the timer, and then you accumulate 5 minutes. And to me, that's actually a really good maintenance routine for people, because it doesn't take long. Number one, you don't need any special equipment, any of that sort of stuff. So I use planks a lot for that sort of thing. And I can have them vary the different types of planks, having them move their arms, change their positions of their knees, all that sort of stuff, and do some kind of more dynamic versions of those sort of things. But that's kind of the way that I use it. Is it's almost more of as a maintenance routine once they've kind of reached a stage where they don't need the greater recruitment, greater engagement, greater strengthening components.
Yeah, I'll do like early phases, 10 seconds on, 10 seconds off, just really tight for 10 seconds to make sure it's really tight. And then as they progress on, you can go a little bit longer, into it. And then you have your plank progressions with your body rotations, band pulls. You can look at your higher level progressions from the heel. So these can be taken further out. One of the progressions I'll use sometimes where if it's a person who's playing a field sport is I will do, it could be cycling or running or aerobic work, could be, lifting cycles, kettlebells, and then I'll go back to it and put it back in afterwards. So I have their heart rate up, I have them fatigued, and then can they hold and do the endurance work under fatigue is another way to advance these. If you're working with a more high level individual, is now I'm into, which is a later phase exercise, probably a phase 4, phase 5, is can they do this when they're fatigued? Can they maintain lumbar stability under duress?
Yeah. Some of those progressions, especially some that develop some rotational components to them, the Spider-Man versions and the reaching under and some of these sort of things that you can do with planks, they're great for athletes because rotational components are very important for that sort of stuff.
Again, pelvic tilting, control and standing, where they'll talk about finding the middle ground between excessive arching and tucking to improve postural endurance. I look for this one as I think about athletic stance. Can I get them into, in that phase, an athletic stance so they can transfer load? Can they load the legs as they're doing that pelvic tilt? So early phase, maybe just getting that tilt to find that middle ground of that arch. Then I'm going to look at, okay, can they do it? Can they sit back, squat a bit, and then rock their weight to their forefoot, the ball of the foot? Like I'm rocking back because it loads the hips first, and then I can roll that weight to the ball of the foot so my hips are loaded versus many times you have that individual squat and load. They just drop the knees forward, never really loading through the hips. They're really just kind of loading through the ankle joint. So their force transmission won't be as great. It's also a less desirable pattern. So pelvic tilts progressed into, the athletic stance, and then it could be plyometric step if they're playing sports, or direction change from there. Modified dead bug, the dead bug can be taken, all different ways, whether it's it's doing this with resistance bands, whether it's doing this with straightening one leg out or both legs out when you come down. The heels can slide on the bed. Shirley Sauerman has progressions for this where you can slide your heels on the bed. So this one can be a dead bug, but the leg lower can be modified a lot. Now, Stuart McGill's got a little rub on some of this just because he thinks this creates torque in the back, but I think it's going to be individualized. If this is creating a shear force, an anterior shear because of the load on psoas and with the stress on the back, it's going to be somebody who probably had a positive, shear test. We looked at anterior posterior stability in the lumbar spine. Is this somebody who had that there? So I use these. I will use those like the levering through this. But again, if they had a stability issue or an instability into the AP shearing, then that may be the person where would I see pain with this. Again, a bird dog, classic one, can be done one arm, one leg, both arms, both legs. It can be done alternating with larger range of motions. It can be done oscillating at end ranges, which is a bit harder, like a stage 5 bird dog is more the oscillations with arm straight, leg straight. It can be done with band resistance. I think they found the bird dog is great for building endurance. It does not build capacity or hypertrophy. As Eric alluded to too, you want those multifidi to blow up like a balloon to stabilize the lumbar spine within the thoracolumbar fascia. Bird dogs won't get you there is what they find. You need more load and hypertrophy training if you've had atrophy or you're in a chronic stage 2 or stage 3, like we talked about. So the bird dog's great exercise, good, shouldn't be the end all be all in what you do. You need something that's going to put more load through the spine. Air pain drills, I like it here. I like single leg. It's think about it. I like it as a single leg hip hinge. It's about dissociating lumbar and thoracic for balance and rotation. The one thing I cue here is that I want this rotation to be occurring around the hip, and I focus on internal rotation of the stance leg with this versus external. I think external is easy, unloads the hip. You don't need as much gluteal control. When you go and you hip hinge forward, a lot of that motion initially you're going to do it with your thoracic spine because the thoracic spine is the path of least resistance. It takes a lot of neural control to eccentrically lower the pelvis and then concentrically pull it back up out of that position in the internal moment. So I make sure that when I'm doing this, that I have an internal rotation moment, the hip, and that's my focus. Did them this morning. Again, respiratory, breathing into the ribs, and you'll see a lot in here in different phases, controlled breathing and diaphragmatic breathing. And these are good exercises to incorporate and have a bucket within your routine there to make sure, okay, am I using this as a relaxation technique for some of these paraspinal muscles? Going back and checking. We are almost out of time. But as you see into phase 3, most of your patients will go to phase 3 and they will be done. In most cases, if we're not seeing somebody who's an athlete or doing something more, you're generally taking people into an endurance phase, and that's probably where you're ending up, unless they are playing pickup sports, they're in high school, they are doing more, they're in a soccer league, they're playing hockey, then you're gonna have to go to probably stage 4 or 5 with them. Most of your patients, once you get to this point where you can get them, hip hinge training with deadlifting mechanics. Split squats with core engagement are another great one. Step down controlled, things, lowering one foot off the step, hip control, pelvic control, bridging, seated to standing, squat patterns. And again, this could be sit to standing with a neutral spine, symphysis, and manubrium, stacked. Eventually, this could be done with weights, overhead pressing. These all can be progressed. Thoracic extension over foam roller. I do a fair amount of thoracic mobility work now. I find it incredibly helpful just to move better. I play tennis, so for tennis, it's been great because this is one of the big patterns I see that's off. So thoracic mobility in there, McGill big 3 again, curl up and progressions. I also put in here a fair amount of band walks in there. I would put a fair amount of single leg work in here. I do a fair amount of single leg and balance work. I think should probably be in this phase as well. I want good single leg control because the most sports you play and movements are going to be single leg sports and movements. I need to be able to load the ankle, the hip, the spine, and be able to control that weight. So I do a lot of single leg squats, single leg cables for split stance cable work, free weight, dumbbell matrix, with the single leg component in there. Eric, anything in there glaringly obvious that, I mean, there's so many things that you could put in here that you would consider, hey, I want this in the program.
No, I mean, obviously there there's a lot of different ways that you can approach this and timing some of these sort of things, but you and I do a lot of the same sort of stuff. My stuff is recruitment, endurance, hypertrophy, right? And so depending on how each person progresses, I like using, especially when I get into the endurance and hypertrophy phases, I like using compound movements that will focus on multiple muscle groups at the same time. Usually I'm focusing on particular sling mechanisms, and we're not going to get into that right now, as far as how the functional movements of the body work and whatnot. We can talk about it certainly at some point, but we're kind of running low on time here. So that's how I do it. And then I'll do accessory things that'll kind of flow in and use some of the same muscles more of in an isolation situation to help improve that endurance, and then eventually to help improve hypertrophy, because you need a certain amount of loading, certain amount of repetition, some of that sort of stuff as far as building muscle and whatnot, depending on what phase you're in. So it all depends on the lens you're looking at it from, and where the patient needs to get to.
So again, there's not 8 exercises in this phase. There could be 50.
Yeah.
So what you're doing and how you're doing it, it's probably worked for you, and that's good. Keep doing it. This is just kind of give you some stimulus. Think, hey, can I think in different patterns? Can I think in different ways? Can I bring some fresh and helpful things in there to make my job more interesting, and maybe the session give it a little bit more pop. So this is just really to kind of spur you into do it, and also framing the way you're thinking. Because if you can frame your thoughts of, hey, where am I with this person? I can do it. If you have a 4-stage or 5-stage program with your patient early on, it gives them direction of where you're heading. They get a sense of where they're going and where they are. So this helps you with buy-in if you sell this to your patients and do this. Like, where are we going? This is where we want to be in capacity to get you back to, evening soccer or the walking programs with your friends. So, having a program or a phase thing like this also helps for patient buy-in. So it's just another way to also use, something like this or your version of this to build it out. And that's what we can talk about. We can chat about these more. We all have different practices and different focuses. So these will all look slightly different, but at least you kind of get a sense of the hallmarks of where we want to work and where we want to go. And again, incorporating the neural control, topics we discussed in class. We looked at the hip, we looked at the lumbar spine. We want to overlay that because any one of these exercises fail. Lateral band walks fail. I can't control the internal rotation moment of my hip, or my foot is collapsing, or I can't create a stable spine. You're going to see that if I get to this phase here, okay, sit to stand. If I'm in a flexion pattern and I can't activate my deep system and stack my manubrium over my synthesis, then it's going to fail. Bridging with pelvic control, same thing. If I can't control my hip or I can't activate my glute or my deep system, the system fails. So everything we talked about in class kind of brings it back to it. I do like to get into standing into that second phase as quickly as I can. Single leg standing, because that's walking. So that is the one thing. If I were to rewrite it, in the Davisms, that would be it. But I wanted to give you, here's some of the top researchers, here's their approaches, here's how they frame it. You have a really good kind of reference point of what is out there and current for us. And then we can start to free form from there. That's kind of like where Eric and I, and probably all of us, are doing to a degree. But it's just good to give you what's in the evidence and then say, how do we use that evidence in our world? Good. That was kind of the goal of today, since we didn't get to go over much exercise in the course, or any at all, actually. Cool. And we are over time. So those of you who haven't dropped off yet, thanks for hanging out. Hope you're not too burnt out from the weekend. Austin, pump up some more details on that. Give people the story as you can, because they're probably all burnt out, ready to hear it. But you can look at that first section we did. I thought Courtney's response was pretty good in what she had going on in there. And then I'm done. All right, guys, have a good week. I'll bug you on the weekend, send some stuff out.
Yeah, everybody.
Take care. Share.